Attorney General Josh Stein, I have the honor of co-chairing the Governor's Task Force for Racial Equity in Criminal Justice. And you are here with us for the second of 3 technical assistance webinars that we are conducting. As you know, states and local governments are receiving and have received unprecedented funds to support pandemic recovery through the American Rescue Plan, or ARP. 2 of the primary purposes of the funds are to strengthen public health responses to conditions worsened by the pandemic and to serve communities disproportionately impacted by COVID. In both instances, several recommendations of the task force address both criminal justice reform and COVID-related mitigation. So we are really thrilled to have you here with us this afternoon, and I hope you will put questions in the chat as they come to you. We know that the problem of addressing violence in our communities has been exacerbated during the pandemic. The American Rescue Plan recognizes these negative impacts and facilitates local governments investing ARP funds to respond to violence in their communities using violence prevention programs. The task force recommendations emphasize the value of having local communities establish violence prevention programs. And we hope that the information you'll get in the next hour will really assist you in considering how you might do that in your community. And just to be clear, the local ARP funds that we are talking about today are those that are allocated to local governments, and they're coming in 2 ways. Most localities have already received their first allocation, roughly 50% of the funds. And this immediate availability of funds is the reason why it's so urgent that we have these technical assistance programs now. With money currently in hand, we know that the conversations are happening at the local level, and decisions are being made regarding priorities for how to use the funds. So the second thing that's important for you to know is that the actual process for determining the use of the funds will vary by local government. Some may use a strictly internal process. Some will have projects they are implementing in collaboration with community partners. And some communities, for example, Buncombe County has developed an RFP that community organizations can use to make proposals. So if you are representing a nonprofit or non-governmental entity, we urge you to contact your local government, find out what their process is. If you are a representative from a local government, consider how you might be open to and collaborate with local communities. So with that, our program today will proceed in 3 stages. We're first going to hear from 2 speakers who will give us an overview. I'll introduce them in a moment. Then we will hear from 2 examples, case studies, if you will, of innovative violence prevention programs that are being carried out at the local level. And then the third part of our program, roughly 20 minutes, will be an interactive question and answer session. And so we really look forward to being able to answer the questions that you have. So first we are going to hear from 2 speakers, Greg Jackson, initially from the National Advocacy. He is the National Advocacy Director for Community Justice Action Fund. His professional efforts have focused on achieving a safer, stronger Washington, D.C. community in multiple capacities after surviving himself an act of gun violence in 2013. So he will give us an overview of violence prevention programs generally. Following right on his heels, we will hear from Adam Levin from the Pew Charitable Trust. Mr. Levin is a principal associate with the State Fiscal Health Project and a national expert on the use of local American Rescue Plan funds. So with that, Greg, I'll hand it off to you.
All right, thank you, Anita, and thanks everybody for having me. One thing she didn't mention is that my family's all from Roanoke Rapids, North Carolina. And I have a bunch of folks in Greensboro and Raleigh, Rocky Mount. So yeah, that's the type of barbecue I like, that side of the state. But I'm really excited to be here and a pleasure to meet most of you all, at least digitally. I'm gonna pull up my slides really quickly and we'll get to it. All right. So while this is loading, I just wanted to start by just sharing, I come to this work I come to this work as a survivor of gun violence. I spent most of my career doing advocacy work, issue organizing work. I I actually served in North Carolina as the state field director for the Obama campaign in 2012. But in 2013, I was a bystander in a shooting in Washington, D.C., where someone mistaked me for someone else. And I'll never forget that experience. One of the things that stood out for me the most was when I entered the hospital, I wasn't greeted by nurses or doctors. I was greeted by 3 investigators who questioned me, dehumanized, and really criminalized me as a victim before I could even get my treatment. And when I was able to meet my doctor, he shared I only had about 20 minutes to live because of the blood loss, and the bullet had hit 2 arteries in my body. And that in itself was traumatizing, but to know that I could have lost my life because of how our country and how specifically that jurisdiction thinks of gun violence and helping survivors was something that really stuck with me. And so I've been committed to helping address this crisis of gun violence, but also recognizing that this is much larger than just the criminal lens or the law enforcement lens that historically our country has taken too far, frankly. So hopefully in this conversation, we'll be able to uplift some of the strategies that work. I'm with the Community Justice Action Fund. Our whole goal is changing the conversation on gun violence prevention by leading with the people who have been most impacted in their solutions and their policy priorities. But I only have 10 minutes, so you can go to our website and learn more. Just a quick reminder, in America, over 100,000 people are injured or killed by guns every year. And when you look at homicides, over 75% of all gun homicides, pretty consistently year to year, are Black or Latinx. One other major factor, which I should put on here in this slide, is according to the Violence Policy Center, 68% of Black homicides are not connected to another felony or crime. And so by only looking at this from a criminal lens, we're overlooking nearly 2/3 of the situations that lead to someone dying violently. And so with that said, we are strong advocates that this is a public health crisis in scale, but also requires a public health response, which includes thinking about how do we prevent violence before it happens, as well as holding individuals accountable after they offend violently. One other big thing is that gun violence is spiking tremendously. We're seeing certain cities across the country have spikes of upwards of 70% from 2020 and 2019. And we know that the reason this major spike is happening is because the root causes that lead to violence are intensified. People do not have safe spaces to go. Youth don't have safe access to recreational centers and schools. Our employment and economic situation is at an all-time worst. Our housing situations are struggling and unstable across the country, and especially in the state. And a lot of the trauma and stress that fuels the cycle of violence has been intensified during this pandemic. And we think that's directly correlated to the major spike we're seeing in violence. One other thing that I always want to remind people, there's a real dollar amount that's connected to gun violence. In America, our economy loses $280 billion. When you look at criminal justice costs, healthcare costs, impact on labor, impact on quality of life, and even cost of living in areas, that $280 billion is a real price tag that we have to live with every year. And that was before COVID. So we're anticipating that price tag is going to be much higher this year, both in lives and dollars. And we've already lost 23,807 lives as of today, which is we're on pace to be more than 2016, 17, 18, and potentially the worst year for gun violence in nearly 2 decades in our country. But with that said, one big thing that we always remind people is that there are solutions, and there are solutions that work. And there's been a great amount of studies focused on why is violence happening in these communities, why is violence happening in Black and brown communities, and who's doing it. And the biggest misconception is that a neighborhood or a community is dangerous, when in reality, less than 2% of a population is connected to 80% of the violence in that given community. And so that tells us that we're really trying to target a small population of folks and figure out how to help and how to support and hopefully shift their lifestyle. We also found that 60% of the gun violence, you can find that through social network analysis. So it's not necessarily hard to find this 2% either. And we also found that 40% of those who are shot or killed, 40% of those who are shot are killed or injured again within 5 years. And so just by doing a better job with survivors and those impacted, we can greatly reduce the actual cost of violence in the country. So when we talk about community violence intervention and prevention strategies, we're talking about programs that really target those most at risk and meet these individuals where they are with different programs, different services, and different resources to help shift their outcomes. So what are those models? I know a lot of you that are on the call probably do some form of this work. So I want to commend you and thank you for what you do. But there are 4 common models of programs that have proven to be evidence-based and successful across the country. They have a lot of different names. So I'm not going to name drop because there's literally hundreds of names. But violence intervention is one of the most common. These are programs that focus on intervening in a personal conflict or group conflict. These are groups that negotiate ceasefires between individuals or between small groups. And they also focus on shifting the cultural norms. Violence intervention programs can be community-based or street outreach, where folks are in neighborhoods, in housing areas, in communities, or they can be hospital-based, where they focus on intervening and working with a survivor of gun violence or a community that's been impacted by violence in the hospital, where that moment is so hot and so passionate, frankly, from the incident that happened. Another key model that we know is really impactful are survivor support programs. Unfortunately, gun violence survivors have very little resources when it comes to therapy, mental health support, traumatic recovery, financial recovery, housing relocation. The gist of what you have access to is either law enforcement controlled or purely health related through the hospital. And so there are a lot of gaps that can be filled that can help people navigate this trauma and frankly live a healthier life, but also reduce the likelihood of them being shot or harming someone in the future. The third one is cognitive behavioral therapy programs. These are programs that work with those 2% or the most at risk before something happens or after something has happened, but maybe it's not fatal for that individual yet. And these programs really focus on shifting the mindset and shifting the lifestyle of the individuals who are most at risk. It is one of the most proactive strategies, but also the most impactful. In places like Richmond, California, we've seen cognitive behavioral therapy programs reduce violence by upwards of 60%. And in some cities, they've actually reached 80% mark in 5 years of violence reduction just by pouring into that 2% and helping them with the lifestyle shift. And a lot of that is not just giving them a job. I spent a year working with one of these programs, and a lot of what we did was helping them develop life skills, conflict resolution. We had weekly therapeutic sessions to help them process their trauma and why they were handling conflicts the way they were, and then assigning a mentor and supporting them as they transition into a new neighborhood or their first 9-to-5 job experience, or first time having custody of their children, but having mentors that help them with a full 360 view of shifting their lifestyle into a healthier, safer one. And then the fourth major model are programs that really focus on the ecology or the root causes that lead to violence. It is very clear that if you have a serious education breakdown or a serious economic breakdown or a serious health issue or lack of access to health and trauma services, all of that directly fuels the cycle of violence. And so there are some programs that purely focus on addressing those root causes and helping the overall health of a community strengthen and grow to hopefully reduce the number of people who become that 2% connected to the 80% of violence. So these are just 4 big models. I'm gonna keep jumping. I think I have 1 minute left. I'm trying to stay on my time here. But what I will say, almost in closing, is that, we've done a lot of work with the White House and with Congress, and we've seen that the president himself and leaders in Congress and leaders all over the country have seen the results. They've seen what these programs and investments can do, and they see it as a smart way to help address violence proactively. And so we're already starting to see some pretty large commitments. The president committed $5 billion in his American Jobs Plan. He adjusted 26 existing grants through executive actions on April 8th to make sure that these types of programs are now eligible. He proposed $210 million in his fiscal year 2022 budget, which is now in the hands of Congress. It was introduced into the House earlier this week. And then he also created a CVI collaborative to organize philanthropy organizations or philanthropic organizations to support these efforts. But the biggest thing, which I think is most relevant now, is that as he rolled out the American Rescue Plan, federal agencies have themselves said that part of these funds should be used to prioritize and support these proactive violence prevention strategies, understanding that the COVID pandemic had a very terrible side effect, which is an increase in gun violence. And so there's been guidance from the Department of Treasury. The Department of Education wrote out a 7-page guidance document breaking down exactly how this connects to education and why it's important and which programs to prioritize. And even Ambassador Rice, the chair of the Domestic Policy Council for the White House, did a memo that she pushed out to governors and mayors this past Monday. So it's been an ongoing push to make sure that these funds are not just pouring into getting vaccines into folks or dealing with our economy, but also dealing with the side effects and the ripple of gun violence, frankly, that is a direct product of the COVID-19 pandemic. So I have one more slide, and I'm gonna pass it over to my man Adam, and he may cover this. But a lot of cities and states have already stepped up and made these investments. This Minnesota, New York, Illinois, Atlanta, Georgia, Knoxville, Tennessee, which is right around the corner, Virginia, Maryland. So many different states and cities have stepped up and started to invest in these programs and started to scale out because they've seen the efficacy, but now they actually have the resources. And so we're hoping that while there's this big spike in violence right now, that we can use these surge of dollars to hopefully help our communities heal, to help intervene violence before it happens, and hopefully help our communities recover from the second pandemic that we're suffering through right now, which is the gun violence crisis. So thank you all so much. I'm sure you will hear from a few more examples of these programs later, but I just wanted to give you kind of a broad overview of what we're talking about when we say community violence intervention and prevention strategies and why they're so critical. So thank you so much. And I will pass it to Anita and Adam.
Thanks, Greg. I will pull up my PowerPoint here, 1 second. Hey, good afternoon, everyone. It's really good to be here. My name is Adam Levin, and I am with the State Fiscal Health Team at the Pew Charitable Trusts, as Justice Earls mentioned. Like Greg, I also have North Carolina connections. I went to grad school at UNC in the Department of City and Regional Planning, so it's especially good to be talking to a North Carolina audience today. I'm going to shift gears a little bit and talk about some of the fiscal aspects of the American Rescue Plan or the American Rescue Plan Act, it's the same thing, and discuss some ways that local governments can manage the funds successfully that they're going to be getting from the legislation. This is something that Pew has provided some technical assistance on, and we're always happy to help out. So one message that I want to convey right at the outset here is that this is a real opportunity for local governments, even if there are some risks that go along with it. The opportunity, I think, is clear. This is a very significant amount of money that local governments are going to be getting across the country as a whole. Cities and counties will be receiving about $110 billion. And as you can see from the map here, for at least some North Carolina counties, the money represents a pretty significant share of their budgets. This uses data from the Census Bureau's Census of Governments, which most recently came out in 2017. And also because the money doesn't actually need to be expended for several years, there are opportunities for local governments to really do some planning now and set priorities for how they want to spend the money for a few years going down the road. And while there are some restrictions on how the funds can be used, there also is actually a considerable amount of leeway. There are a few broad categories that outline the permissible uses. So the first one is responding to public health and economic impacts of COVID-19. Another one is responding to disparate impacts that the pandemic had. Building infrastructure and supporting essential workers are two other categories. And then lastly, for local governments that can document that they had revenue loss specifically due to the pandemic, there's expanded eligibility for how they can use the funds. For purposes of today's discussion, and as Greg was mentioning earlier, I think it's worth noting that violence prevention programs are specifically mentioned in the legislation as a permissible use of funds under the disparate impacts clause. I'll spend the rest of my time going over some high-level principles that local governments can use to manage the money. And the biggest risk that they might encounter is a so-called funding or fiscal cliff. And this happens when local governments or states put one-time money towards ongoing services or programs. And the spending cliff, the fiscal cliff, excuse me, happens when the spending commitments remain, but that money expires. This actually happened with the American Reinvestment and Recovery Act significantly in 2009. A lot of the ARA money actually expired at the end of fiscal year 2011, but local governments as well as states had put a pretty good share of it towards ongoing spending commitments. And when the money expired at the end of fiscal year 11, there was sort of a new round of budget cuts and budget shortfalls that local governments experienced. This graphic here illustrates the principle. It is using federal and state data, but the idea applies to local governments too. You see the funding cliff happening there in around fiscal year 2011, 2012, when the ARA money started to expire, but states and local governments still had the spending commitments that they had created with the money. So one thing that can help manage this risk is thinking and forecasting long-term. ARPA is a huge amount of one-time funding. And so local governments should analyze what their revenues and what their budgets are going to look like when the money expires. And because it is pretty difficult to do this type of forecasting, or at least it can be, they should do this under multiple scenarios. This may reveal lasting or temporary changes as a result of the pandemic. So for example, tourism-dependent regions were battered during the pandemic. That's been well documented. But as COVID begins to fade, they may bounce back quicker than some other regions, and those other regions may face more lasting challenges. Ultimately, the goal of this type of analysis is to determine where ongoing revenue is going to be in the long term, because again, putting one-time money, such as that from the American Rescue Plan, towards recurring or regular spending commitments is where local governments face going over a fiscal cliff. Now, there are instances where putting one-time money towards regular recurring spending programs can actually be a good use of the money. So for example, if revenue forecasts show that revenue is temporarily depressed, but is expected to recover to sustainable levels where it can support ongoing programs, using the one-time funds as sort of a bridge to get to that point could be a good use of the money. And similarly, on the expenditure side, forecasts could show that certain programs are experiencing a temporary spike in demand, at least at the state level. For example, Medicaid during the pandemic is a good example. But those demands are likely to ebb as the pandemic goes away or as other circumstances begin to change. And so using one-time money to address that spike in demand and spending could also be a good use of the funds. But I do want to emphasize that the money that local governments are getting from ARPA, is a real opportunity. And we've seen a number of local governments throughout the country put out plans or even start allocating the money already, which suggests that they see it in the same way. I have a few examples here. I'll just point out one, which is from Fairfax County in Virginia, very close to where I live in Washington, D.C. The county will be spending money on retail assistance, behavioral health care, upgrading IT projects, and other spending commitments. And I know we're focused on violence prevention today, but I did just want to quickly mention some other types of spending or programs that align with these principles. And some of them could have both fiscal and economic benefits. So one example is deferred infrastructure maintenance. It's actually a pretty big liability for local governments and for states where infrastructure buildings that they own are in need of repairs, but those repairs just sort of continue to be kicked down the road, not being addressed. Using this money for that type of spending could have fiscal benefits because putting a big dent in the total outstanding liability will help from a budgetary perspective. It could also have economic benefits as spending on infrastructure could create jobs and things like that. Broadband is also a use that aligns well with these principles. It's the type of project or program that can clearly benefit from a one-time investment and also has economic development impact. I think it's also worth mentioning, particularly for today's discussion, that ARPA specifically mentions program evaluation as an approved use. So this could give local governments time to experiment with new programs, create pilot programs, things like that, as long as if those programs turn into permanent spending commitments, local governments make sure that they have enough ongoing revenue to sustain them in the long run and avoid falling off a fiscal cliff. So that'll do it for me. I'm happy to stick around and take any questions that you all may have. And for now, I will turn it back over to Justice Earls.
All right, great. Thank you so much, Greg and Adam. That was incredibly helpful information, and we'll look forward to hearing more from you in the question and answer period. We are next going to hear from Amy Vincent. She is from the Virginia Commonwealth University Health System. She is the Assistant Director for Injury and Violence Prevention Programs and also a social worker. She works to reduce and prevent traumatic injury across the lifespan, and she's worked in the prevention field for over a decade. So Amy, thank you so much for being with us today.
Hi, thank you. Thank you so much for having me. And I'm going to share my screen. I have a few slides. Okay. Are you able to see the slideshow or the notes version?
Right now, I think we're seeing the notes version.
Okay, let me swap. How about that?
Yes, now
Thank you. Great. So again, my name is Amy Vincent, and I'm the Assistant Director for VCU Health Injury and Violence Prevention Programs. We are your neighbors to the north. We are located in Richmond, Virginia. I'm going to do a brief overview of hospital-based violence intervention programs and then focus specifically on what we do in Richmond and with our Bridging the Gap program. So hospital-based violence intervention programs work with the patient and their family or their positive support network to connect them with the resources that they need to meet the goals that they're setting for themselves. I think one of the most important things to know about a violence intervention program like HVIPs is the idea that we're working with not just the patient, but we're working with their family to wrap them with the support that they need to be safe and healthy and to meet those goals. So we offer a multidisciplinary program, bringing together hospital staff, we bring together community partners, and the idea is that we're creating safety planning, we're doing warm handoffs to our partner agencies, and we're providing trauma-informed care to those who have been injured due to violence. One of the most important things is that engaging patients in the hospital during the recovery is really a golden opportunity to improve lives and reduce retaliation and recidivism. So it's a unique opportunity. This is the only other time where you're going to have the moment with a patient who has most likely, come close to a near-death experience. It makes the intervention a little bit more hefty in that, this is the best opportunity to reach them when they're most likely alone. Oftentimes support networks have either stopped coming to the hospital or due to COVID are not allowed to come to the hospital. So they don't have the supports that they need while they're in their recovery period. So we can come and be that support while they're at the hospital and beyond. So treat to street to treat again is unfortunately a model that's seen across the country at a lot of trauma centers and community hospitals that don't have programs like hospital-based violence intervention programs. Our program called Bridging the Gap was started in 2007 by our director, Dr. Abatanos. And it was started because he was just physically and emotionally exhausted from having to tell parents, having to tell mothers, having to tell brothers and sisters and friends that their loved one had died. It became a revolving door for him, and he knew that we could be doing better and we should be doing better. The hospital is an integral part of the community and has a vital role to play. So he often tells the story of one patient in particular that was sort of the impetus for getting this program off the ground. In probably 2005, 2006, he had a 16-year-old patient who came in for a pretty severe gunshot wound to the abdomen. It required multiple surgeries, a lengthy hospital stay. This patient went home with home health care, but they were successful in that he survived and that he was able to go on and to live his life fully after this incident. So, we think, all right, we've done our jobs. This is what our job is to fix people, make them whole again, and send them back out. But he came back again. He came back a few months later, and he had another pretty devastating wound to his leg. He was actually very close to losing his leg, and they were able again to save him. And they thought, wow, we've done such a great job. We've saved this patient. He's going to be able to go and live his life fully. A few months later, he came back a third time. And he came back with a gunshot wound to the head, and it was fatal. And they couldn't save him, and they had to talk to his family, and they had to listen to those guttural cries that come from our patients' families when they're losing a loved one, when they've been told their loved one isn't coming back. And he said, that's enough. That's enough. There has to be something more that we can do. We know, and these statistics are for today, but we know that the 5-year re-injury rate for victims of intentional injury is somewhere between 10 and 50%. Generally, it's closer to the 50% range if patients aren't enrolled in any type of service. 20% of those patients that we see are estimated to die as a result of subsequent violence. So re-injury leads to violence. Re-injury leads to fatalities. Within our own health system, our trauma registry is reporting about a 15% re-injury rate for those who are not enrolled in our program. And for reference, we see about 4,300 to 4,500 trauma admissions per year, and 12% of those are firearm stabbing injuries. And we are a level 1 trauma center, and we see close to 90% of the gunshot wound injuries in the city of Richmond and the surrounding counties. So from that, we knew hospitals got a vital role to play in violence intervention. It is a public health issue, and healthcare is a part of public health. Oftentimes, the hospital becomes a revolving door, and that's not our role. This is why healthcare needs to be a part of the solution, and why hospital-based violence intervention programs exist, and why we exist today. So I'll tell you a little bit about our program. Bridging the Gap is, we were established in 2007. It's an HVIP, which really provides intensive case management at the bedside for patients who have been violently injured due to gunshot wounds, stabbing, or assault, ages 10 to 30. And we extend that intensive case management post-discharge, once they're discharged back into their community, for up to a year. And we base it on the needs of each patient. So through intensive case management, we're really working with community partners and our patients to address disparities that contribute to violence. So what do we offer? We offer 3 basic services. We offer a standard of care, which is offered to every single patient who walks through our doors, who is a survivor of a violent injury. We offer intervention at the bedside, which I'm going to focus on in our next slide. And this is for youth and adults who have been violently injured. And then we also have a prevention program called Emerging Leaders, which I will address again too. So it's the prevention arm to Bridging the Gap. We know that yes, we have to have intervention because we have to serve those who are currently being injured, who are currently at risk, but we also need to have a way to stop it from happening first. So our intervention at the bedside, I should state first that our standard of care is for every single patient who walks through our doors, regardless of age. We provide them with information and referrals and advocacy while they're in the hospital. Because of, I want to say capacity, basically, we only have so many case managers. We're not able to serve those past the age of 30 with intensive case management post-discharge. So right now, our intervention at Bedside is for those that are ages 10 to 30. So our goal is for our patients to have the opportunity to live a long, healthy life. And we do that by relationship building at the bedside. So our case managers will follow patients while they're in the hospital to build rapport. I would say on average, it takes about 5 visits to the bedside for a patient to say yes to enrolling, because they have to build that trust with that case manager. We have to have the right relationship for someone to be willing to let us in. We also provide intensive case management. So our case managers assist patients with accessing services, facilitating coordination between all the systems that might be involved in their care. And we provide a link to community resources. We know that we can't do this alone, so we have to have a good network of community partners. And then we follow patients post-discharge. So that's the community reintegration piece. Case managers follow patients for up to a year. This is really shown to increase the success of patients meeting their goals and reduces re-injury and recidivism. I'll also touch a little bit on emerging leaders. So what we were finding with our Bridging the Gap patients was that about 85% of them had been seen in our health system at some point prior to their injury. So we thought there has got to be a way to reach these patients before they are injured. How can we do this? So we started looking at working with our pediatric emergency department. We are a level 1 trauma center for both adults and pediatrics. So we have the opportunity to work hand in hand with our peds department. So we worked with them to provide referrals for those, and we had specific markers for those who would meet criteria. So Emerging Leaders works with young people ages 14 to 18 who are low to moderate risk for becoming involved in violence, either as survivors or as perpetrators. Our goal is to stop it before it happens. So we focus on creating opportunities that are aimed at success for youth and their families. We know that a young person can't do it on their own, so we often wrap in their support services or their support systems as well. We really built on the success of Bridging the Gap, and we include 7 components with Emerging Leaders. Number 1 is identifying our at-risk young people, providing intensive case management. So we do the same type of case management that we do for our Bridging the Gap patients, so that we can encourage that young person to meet their goals with the right support systems. We provide educational development, skill building, exposure to healthcare careers, employment opportunities, and that wraparound warm handoff service delivery. The employment opportunities and exposure to healthcare careers is sort of what sets us aside from a normal community program. We work with our internal departments. We know that a hospital is basically a standalone city. There are so many opportunities for career paths within a hospital. There's doctor, nurse, physical therapist, rehabilitation. There are so many avenues, but there's beyond that, there's electrician, there's transportation, there's food service, there's this wealth of opportunities right at our fingertips. So we've tapped into that, and we offer paid internships over the summer to our participants in an area that they're interested in. So we're giving them the opportunity to experiment and kind of find where they fit in the world. The other thing that I wanted to mention with Emerging Leaders is that young man that's sitting in the center of the circle here. He actually works with us now. He enrolled in Emerging Leaders in 2017 after a gunshot wound and has done a lot of work. He should be really proud of himself. He was hired into our patient transportation program and was working with patient transportation for about a year and is now actually working with Bridging the Gap. He is now a peer support specialist with us, and he's amazing. He's able to connect with patients in a way that most aren't, because he's walked in their shoes. So I do want to talk a little bit about key stakeholders. I think if you're looking to start a program like this, Number one is you need to connect with your level 1 trauma centers. If you're looking at a hospital-based violence intervention program, your trauma centers are going to be your key investment. They are the ones seeing the patients. They are the ones taking care of your patients. So start with them. Rope in those hospital champions, your trauma program managers, your trauma surgeons, hospital CEOs, even your nurses on the units, because they are going to be the ones that really have an understanding of what this is going to take. Your other key stakeholders are your community. Your local health department. I saw a question about how do you make this a public health issue? Tie it into your public health department. This is their bread and butter. This is what they do every day. And we know that violence is a public health issue and a public health crisis. So tap into those resources. Tap into your cure violence and other intervention models. I know David's going to talk after me, and he'll be able to tell you a little bit about the Bull City model. Tap into your coalitions. Often there's coalitions working to reduce violence in cities. You know, that's where your community service providers are going to be sitting. That's where you can get your seat at the table to learn about what's already happening within your community. Your community members and survivors of violence are also going to be your key stakeholders as well. You want to talk to those who have walked this path. You want to utilize their life experience and their expertise in creating your program as well. So the objective of our program was really to do a thorough evaluation. So we did an evidence-based program, prospective randomized trial, and we looked at a brief violence intervention at the bedside with no community follow-up versus a brief violence intervention with community-based intervention, which is what Bridging the Gap is. And what we see is a reduction in recidivism from 15% to about 3.6% for those that are enrolled and complete the program. We see reduction with short-term risk factors. We see that there is about a 2.5 times decrease in the use of alcohol, and also a significant reduction in drug use. Hospital service utilization, we see our clinic visits, our patients are more likely to show up to visits and to utilize those visits for what they're intended for, which ends up reducing the use of the emergency department inappropriately. So when we know people are getting the care that they need at their clinic visits, and they're asking the right questions, they're less likely to have infections or have other types of things pop up that could have been addressed in the clinic visit. And then lastly, community service utilization. Our patients are 2.5 to 3 times more likely to use community services at 6 weeks, and then respectively at 6 months. And about 90% are connected by that 6-month mark. I'm going to briefly touch on funding needs. I'll tell you how we're funded. So we were funded through, Virginia itself was funded through an initial investment from the governor of $2.45 million through VOCA funding. And this funded 5 hospital-based violence intervention programs across the state. We were the only one that was already in existence, so it stood up for others. Plus training and technical assistance. And with full disclosure, VCU is the training and technical assistance provider for Virginia right now. These funds were passed through the Virginia Healthcare and Hospital Association, and so they are our funder. We're funded through a variety of sources. We have funds, obviously, through the Virginia Healthcare and Hospital Association, through those VOCA dollars. We have funds through the health system, and we also have funds through our Department of Health. We've been in existence for 13 years, so our program is pretty robust. We have 1 program manager, 5 full-time case managers, 1 full-time therapist, and 4 part-time peer support specialists. Year to date, that allows us to serve about 250 patients, and we are estimated to serve about 400 patients in 2021. If you're looking for a startup budget, we're looking at 1 program coordinator and 2 to 4 full-time case managers, depending on your who you plan to serve and how large your catchment area will be. You want to have funds for emergencies, so crisis funding to help keep your patients stable. Supplies, training, you want to have really great training opportunities. You want your program staff to feel prepared. Local travel, we do go to people's homes, so you want to make sure you're addressing the need for staff to be able to go into the community. And then software for program data collection. So we're looking in the range of about 250 to 350,000 per hospitals. ARP funds can be used as seed money. I know Adam mentioned the fiscal cliff, and it's real. But if you're utilizing these funds as seed money to get these programs up and off the ground, the idea is that this is proof of concept for hospitals then to invest in this and to take those programs and take that burden of cost. And I will stick around for questions as well.
Yeah, so sorry to cut you off.
Yep.
This is amazing. Thank you so much. I want to invite our Dave Johnson to join us. And then Amy, I want to assure everyone who has put questions in the chat that we will work through them. And people had questions for you, Amy, as well. But I want to make sure that we hear from Dave Johnson, who is supervisor for Bull City United, which is a violence interrupter program in Durham, North Carolina. Mr. Johnson became involved with gangs at age 15, and at age 17, he was incarcerated. He served 10 years. Today, he's using all the tools he has gathered and the credibility he's developed to interrupt the cycles of violence that have claimed so many friends, family members, and neighbors. So Dave, please, we're eager to hear about your program.
Yes, ma'am. How everybody doing? I'm gonna try to share my screen to present this presentation, and I will try to make it as quick as possible. Try to stay on the time frame that I know y'all had requested. So let me try this. Share screen. Sorry. Am I being seen by everybody? I'm sorry.
We are seeing that, yes, we are seeing your screen and the outline of your PowerPoint.
Okay. Well, like I said, Bull City United is Durham County community-based intervention and prevention program. We use the care violence model, which states that we treat violence as a public health issue and not a criminal justice issue. And we'll keep going from there. Sorry. The care violence model states that we work in to work to detect and potentially violent conflicts. We prevent retaliations. We mediate ongoing conflicts. We do this by identifying and treating the highest risk individuals in that community, by accessing the highest risk, changing their behavior, and helping them attain services through education opportunities, work services, anything that we can provide those individuals that can help them change their life. Mobilizing the community and changing the community norms. We do this by responding to every shooting in our target area or assigned area that we operate in, and just to let the people know that they have an organization out there that's with them, helping them fight this violence that's going on and plaguing our community. Bull City United, as of right now, the team structure right now is a supervisor, which is myself. As recently as last month, we have added on to our violence interrupters and our outreach workers. So as of to this date, we have 9 violence interrupters and 5 outreach workers. I want to say through we just had a recently agreement with our city to invest 900 and something thousand into our program. We was able to build out 18 more positions to into folks into Bull City United. Our programs was picked off 2 6 tracks when we first got started in 2016. Those 2 census tracks was the highest 2, had the highest 2 shooting volumes in the whole city of Durham. That's why those 2 census tracks was chosen, which was the MacDougal community and the Southside community of Durham. As you can see the violence rate and the violent crime rate per person in the city. This is some of the things that we have accomplished as far as mediations and shootings in our community. As you can see, man, I cannot see this. Let's see. As you can see, we have from our recent most data from January of this year into April of this year, the mediations, the shootings, and the killing data that we have been in our assigned areas. So as you can see, through those four months, we have 0 killings in our target area, and less than a couple of shootings each month. So we have been very targeted in our responses to shootings in our area, and also encouraged by the no killings that's been going on in our areas. As of January through April, we had mediated 233 conflicts involving 581 people. As you can see the percentages of what those conflicts stem from. I could say 61% of those mediations was likely to result in a shooting or somebody being shot. And I say 80% of those mediations were successfully resolved, and nobody was harmed through our mediations. As of right now, today, we have 43, well, from January to April, we had 43 individuals on our caseload. And to be on our caseload, you have to check off numerous boxes, but our main criteria that we try to look for is if a person is a gun toter or a gun holder, we target those people. We want to be in those people's lives, and that's somebody we try to pull in and be a part of the program. The impact on participants. 91% of the participants we work with are employed. Was connected to employment. I'm sorry. 57% are actually employed right this moment. 100% receive services to change behaviors, and 79% show gun-related behavior change, and that's not carrying, not getting locked up for guns, and just things of that nature. Some of the events and things that we throw throughout the community to change the community norms. We hold a Week of Peace event down here in Durham that we do every year. And it was recognized through our Board of County Commissioners as recently as this year. It's called the Week of Peace, where we take out a week out the year to recognize the people that we have lost to gun violence, and to advocate for going throughout this next year and try to get no shootings and killings in our community. So we do a lot of events like these just to break the normacy, or try to encourage interaction with Pieces of Lifestyle, which is Wood City United, which is our group, which is our message. So through events like these, man, we try to change the normacy of the community, and just give back to the community. And with that, I will be here for any questions at the end of this thing. Thank you.
Thank you. It's very encouraging to see the data you have on the results you're getting and all the work you're doing. Thank you so much. I really want to invite, so please stay where you are. And I want to invite all of our other panelists to join us back on screen. as they're coming on, I want to let everyone know that if I don't get to your question, or if there is further follow-up you want, please know you can email us at criminaljustice@ncdoj.gov. Again, that criminal justice, all one word, at ncdoj.gov. I will put that in the chat, and we will try to respond to your questions or get you the information that you need. So we did have a lot of questions in the chat. I think some of them have been answered as we've been going along, but I'm going to go back to a question that I think was for Greg, and to some degree, people have talked about it, but how do communities move towards addressing and advocating for gun violence as a public health issue?
Yes, well, we have quite a few people who are a part of this event who are part of our coalition in North Carolina, but I think the first thing is just making sure your elected officials understand the scale of violence in your community and how the impacts are harming communities. But then secondly, breaking down the solutions that exist. What we found, whether it's a city council member or a congressman in Washington, is that there's very small amount of knowledge in our elected officials about what are the options that exist to address violence. The dominant narrative is more police, more enforcement, harsher sentencing, but we have to kind of open people's minds and show them some of these evidence-based practices and programs that exist and are thriving. And so I would say first, make sure they understand the scale, try to do some type of briefing or presentation to break down the solutions that exist. And then from there, we can advocate to the stakeholders and folks that need that help. I will say at Community Justice Action Fund, we do every quarter, we do a training called Justice Camp. We actually just finished our last one yesterday, where we train people on advocacy strategies and tactics and how to effectively push that message. But honestly, it has been very simple in this case because a lot of these solutions work so well. And you've heard from Amy and David, they're seeing a lot of results with a little bit of resources. And so we have so many test cases that we can put before our leaders that really sell it for us. So yeah, so hopefully that's helpful.
Yes, thank you. And I think this is, next question is also one really generally for everyone, and that is, do these models incorporate racial trauma therapy for those who exhibit internalized racism? That was the question.
So I can take that. So we don't necessarily have therapy specific to that, but we do have a trauma psychologist on staff, and we do provide counseling for all of our patients and participants through counselors in our program. And then whatever we're not able to take on because of capacity, we refer out to culturally competent providers in the community as well. So I think it's a great idea, and I love that. And if there were more capacity, we would certainly be focusing specifically on that too.
Yeah, I'll just add, I mean, I've definitely seen programs that integrate those types of strategies. The Pathways program in DC, as part of their weekly therapeutic sessions, they do cover kind of institutional racism and how does the impacts of racism, how is that feeding into their trauma and their perspective on both themselves and how they deal with conflicts in the broader society. So I do think it's a really smart thing to incorporate. It's not necessarily the norm, but I think it's very valuable wherever it is incorporated.
And then another question, and I hope all of you will feel free to chime in if you have information that's useful. We have a question of whether there is an example of a domestic violence prevention program that could work well with ARPA funding.
I don't have one off the top of my head, but I will say there is a whole sector of these programs that do specialize in addressing domestic violence. And we're working on kind of a policy playbook on that. Hopefully we'll be able to release later this summer. And so if you follow our information, you'll get that policy playbook that breaks down some of the community-based strategies to address domestic violence. I will say though that a lot of these programs, especially the cognitive behavioral therapy programs, a lot of the conversations in the development is focused on healthy masculinity, right? And how do you navigate not only your relationships in the community, but in your relationships in the home. And so I will say that a lot of these wraparound programs do cover some of the things that hopefully can prevent someone leading down that direction of domestic violence. But there also is a whole kind of, there's a whole lane of organizations that do specialize in this, and we can try to circle back and get that to you.
And then we had a series of questions that came up during Amy's presentation, and so I'm going to try to just rattle them off, Amy, and see what further information you can provide. But people wanted to know more about what type of legal services are offered as part of the program. Another question of whether, if you could talk more about the funding for your program more generally. And then a question about whether or not, and this may be for everyone, but whether these models can be applied to rural service providers that may have hospitals but don't have a trauma center. So let me start with those three.
Okay. The first question was, can you repeat the first question again?
Legal services. Tell us about the
legal services. So we don't provide legal services. We don't provide legal advice, but we do refer out to our partners in the community who do that. So we often work with legal aid or other providers who provide some pro bono work, but we don't necessarily provide legal services or advice. I'll come back to the funding question because I think the rural question is actually a great one, and something that we've been working on in Virginia is looking at what can you do if you are in a rural area. Most rural areas don't have trauma centers, but that's okay. If you are seeing increased violence, which a lot of our rural communities are, at least in our state, and I assume it's not much different in North Carolina, there are programs like our Emerging Leaders program where you maybe are doing some more prevention work, but you also can do a smaller version of a hospital-based violence intervention program. You still have all of those same resources at your fingertips through your emergency department at your local community hospital too. And then funding. So I guess more broadly, I'm not sure what the question is asking.
Well, so they said that funding these programs is so important. So I guess any advice you would give to a community that wanted to get a program like you've been underway for a long time, you're well established.
Yeah.
What advice in terms of finding funding would you give to a community that wants to establish something like what you're doing? So
if you work at your local either community hospital or a trauma center, I think it's talking to your leadership. That's how we started, was an initial investment from our hospital CEO. He saw the need because Dr. Abatanos was able to show him the data, the numbers, and how it would help the hospital save money. I mean, sometimes you have to talk about the dollars, which is the sad part, because it's about individual lives, not money. But sometimes that's what you have to show first. So we got our initial seed money from our hospital CEO. He was willing to invest in a half-time case manager, half-time. So even with a small investment of that half-time case manager, it allowed us to prove the concept over a 2-year period, and we were able to gain more funding to grow to a full-time. And then once Virginia opened up the funds for hospital-based violence intervention programs, we were able to expand to 5 case managers and those 4 peer supports. But if you're looking to get started, like I said, talking with your hospital leadership, pulling data, your national data, you want to look at places like the HAVI, the Health Alliance for Violence Intervention. They are our partners. We are a member of their organization. They are your national hospital-based violence intervention network. Reach out to them as well. They are going to provide you with more national statistics, connect you with other hospitals as well. We're happy to be a resource, but it's always good to hear from other hospitals who are doing the work too. So you have multiple perspectives. And then tapping into those ARP funds for maybe that one-time funding to get you up and running.
The only quick thing I would add is, I put it in the chat, but in April, 26 government grant programs were adjusted to be more inclusive of these strategies. And so there's a lot of new funding. It's about $10 billion in total. Now, mind you, you're competing with other organizations that are not violence prevention focused, but that is something that's here now that you can apply and pursue. So please don't overlook that. And I put the link in the chat here.
Well, finally, I'll just say we did have a response in the chat on the question of domestic violence. And for those who are watching on YouTube and don't have access to the chat, there is in North Carolina, the North Carolina Coalition Against Domestic Violence that has models for prevention efforts around domestic violence that align with this notion of outreach and the understanding that that violence is a public health issue. And finally, this is gonna have to be our last question just because we're running out of time, but for Mr. Johnson, who did you work with in local government to support your programming? Where did you start in the process?
I wanted to say it started with our former health director. She went out and seen the model, and she brought those ideas back and she did a presentation. So Durham County actually gave, I want to say, a $500,000 investment to initially start Bull City United. And we have taken off from there. Now we have partnerships with the city side of the government. And I also think we just got a grant from Representative David Price also. So we've been doing a lot of grinding just to seek funds and things of that nature since our first initial investment.
Well, I just want to say how grateful I am to all of our panelists. We could have spent an hour or more with each one of you, and what the work that you're doing and what you're talking about is so central to the most important recommendations that our task force issued. Reimagining public safety and how to work with communities and I think I also just have to say, one of the biggest insights I think the task force that I learned through participating on task force is the fact that it is wrong to think of perpetrators and victims as two separate groups. They are incredibly overlapped. So all of the victim interventions that you are engaged in really is preventing violence. And so I want to thank you all for your work. I want to thank you for being with us today. I'm enormously grateful to our staff who put this panel together and who've been working so hard around these issues. And thank all of you who attended today. Again, if we didn't get to your question or you have other questions for us, email us at criminaljustice@ncdoj.gov. And I will be respectful of all your time and conclude this session for today. Thank you.